A very good afternoon to one and all. I welcome you all to the classroom series of Neurocritical Care Society of India. Today we have with us Dr. Soumya Madhusudhan. She's done her DM Neuroanesthesia from Sri Chitra and done her fellowship in Neurocritical Care from NIMHANS and her Neurocritical Care training from Addenbrooke's UK. Madam is presently an assistant professor at Surgical and Neurointensive Care Unit at St. John's Medical College. She will be discussing a very important topic which is very relevant, which is intracerebral hemorrhage. Welcome, ma'am. Over to you, ma'am.
Thank you, Dr. Mathangi, for this opportunity. Today, the outline of our talk will be in terms of, we'll describe the classification of the ICH, the etiology, the pathophysiology of hematoma expansion, the clinical presentation as how it presents, the scoring systems which are important in the ICU care, the radiological aspects and the early medical management, the definitive neurosurgical management and landmark clinical trials which are very important in ICH, and what are the clinical practice recommendations that we have in case of ICH. ICH is defined as a non-traumatic hemorrhage into the brain parenchyma, including or not including the ventricles. The two most important risk factors that results in ICH are hypertension and cerebral angiopathy. Looking at the ICH, it accounts for about 6.5 to 20% of our caseload of the stroke. It has a high risk of morbidity and mortality than any other forms of stroke, be it cerebral infarction or SAH. No therapy is proven benefit in the treatment of ICH, and it's very challenging. Looking at the outcome, the 30-day mortality in case of ICH is about 40%, and ICH patients, if they are managed well, they are independent at 6 months, about in 20% of the cases. So, what are the risk factors for the ICH? Hypertension is the most important risk factor, which results in the degenerative changes in the arterioles and results in the ICH. Smoking, high alcohol intake, like a binge drinking of alcohol or more than 30 drinks per month, it results in causing platelet dysfunction, inducing coagulopathy, increases the risk of ICH. Cerebral amyloid angiopathy, where there is amyloid deposition in the leptomeningeal and your subcortical vessels, that results in a rupture and ICH. And diabetes mellitus, which increases the relative risk about 1.6% of times of having an ICH. And definitely the patients who are on aspirin, warfarin, and direct oral anticoagulants, there is an increased risk. So based upon the ICH causes, we can divide the ICH into the primary ICH and a secondary ICH. The most important reason for our ICH when there's is hypertension and cerebral amyloid angiopathy, we call it as a primary IPH. In case of secondary intracranial hemorrhage, the mainly it is because of the vascular lesion that is present and it results in ICH. Most commonly, it is the arteriovenous malformation which presents as an ICH. Remaining ones are the cavernous malformations when we have a mycotic aneurysms, cerebral venous thrombosis. Another important reason we come across Moyamoya disease, vasculitis, and metastasis or an hemorrhagic conversion of the stroke. So these are the causes of secondary ICH. So, what is the burden of the ICH? Initially, when the ICH happens, it causes a primary brain injury because of the mass effect. It will result in increase in the ICP, reduction in the cerebral blood flow. It gives a reason to the many secondary brain injuries in the form of hematoma, expansion, perihematomal edema formation. It stimulates all the inflammatory cytokines and results in several injuries causing secondary brain injury. So, how do they present to us? Usually, in the primary ICH, the most common clinical presentation they have is acute onset headache, nausea, vomiting, seizure, focal neurological deficit, blood pressure lability, or the hypertension, and a depressed mental status. So, is there any features that will help us differentiate from the other type of stroke? Usually, ICH, once they have the onset, they deteriorate progressively. There is no point of improvement till they are managed. The acute onset headache, having nausea, vomiting always points towards having an ICH. In case if your ICH, the secondary ICH is because of the vascular malformation, what difference you see is they are much younger age group. They do not have an history of hypertension. They have seizures because they have more of non-lobar or a cortical involvement, and they give a recent history of dehydration, pregnancy, hypercoagulable disorders, which will give you a diagnosis towards CVST, that is your cortical vein thrombosis. So once we have established the clinical diagnosis, we have an ICH, it is important to prove it by doing your imaging. The more initial diagnostic modality of choice is a non-contrast HCT. So how do we identify the ICH? In the first minute of the ICTUS, usually The hematoma remains isoattenuated to that of the gray matter. As the time progresses, within 1 hour, the attenuation increases, becomes hyperattenuated, and appears as an hyperattenuated mass in an acute state of ICH. Later, the attenuation reduces and it comes equal to that of white matter. It undergoes resorption and loss of the brain parenchymal tissue and results in gliosis. This change takes about over 2 weeks. After this, once we identify there is ICH, it is important to localize the location of the ICH, whether the ICH is in the supratentorial compartment or in the infratentorial compartment. Once in the supratentorial compartment, that is above the tent, you identify the location, whether it is near the basal ganglia, it is near the thalamus, or in the lobar areas, or you have to look in whether it is in the pons or the cerebellum in the infratentorial area. It is very important in the management of the patients. After identifying the location of the hematoma, the next thing we have to see is the hematoma volume. The hematoma volume is the strongest predictor of a 30-day mortality. It is very important, the management. If it is less than 30 ml, the mortality is about 20%. If the hematoma volume is more than 70%, you see your mortality is going to be a 90%. So it helps in the prognostication of the patient during the ICU care. So how do we assess the hematoma? We have the volumetric assessment methods. One is done by manual, the other one is done by the fully automated ICH identification technique. Basically, it's a software that comes along with the CT machine. So we have a formula which is the ABC by 2, or you have an MABC by 2, which is called as a modified ABC by 2. So going by this formula, this is called the Tada formula. It is commonly referred as ABC by 2. A is the largest diameter of the hematoma you see in the slide, and B is the largest diameter perpendicular to the A, the line B. And you see the C, which is the number of slices in which the hematoma is seen, and you multiply that by the slice thickness. It can vary anywhere to 1 to 5 millimeters. So when the bleed is irregular, it results in under and overestimation of the volume. Therefore, having an automated techniques are better. We did a non-contrast CT. We have to identify why is there is a cause of ICH. Is there any vascular malformation? For this, CT angio is effective modality for diagnosing the underlying causes. The radiation exposure and the risk of contrast-induced nephropathy makes the CT angio not a part of routine workup, but the guideline says in 2022 it is reasonable to do a CT angio to assess the risk of hematoma expansion. We have several signs on CT angio that will predict our hematoma expansion. So these are the specific signs we see on CT angio and on CT, which will indicate that your hematoma is going to expand and the patient can have neurological deterioration, and we take adequate measures to prevent this from happening. So the spot sign, what we see on the screen, is the first thing that we see on CT angio. The rest of the signs are seen on patients with a non-contrast CT. So what is spot sign? We see two focal enhancement that is seen within the intracerebral hematoma. They are the contrast extravasation. That means it indicates it's an active bleed that is happening into your hematoma. The hematoma is going to expand. When do we call it as hematoma expansion? When the hematoma volume increases by 6 ml from the present scan, it indicates a hematoma expansion. Whereas this is the swirl sign. We see this in patients with non-contrast CT scan. You have areas of isoattenuated along with hyperattenuated areas. So this indicates the bleed is of different time periods and the active bleeding is going on. And this is a black hole sign where you have a hypoattenuation with a hyperattenuated ICH mass. It is not linked with the brain parenchyma. This also indicates your hematoma is expanding. The most important is the blend sign, where you have hyperattenuation followed by the isoattenuation around this. That means the bleed is of different densities. It indicates there is active hematoma expansion. Unlike the swirl sign and the blend sign, it has a definitive borders of isoattenuation and hyperattenuation, whereas the swirl sign is quite mixed. It doesn't have the areas of iso and hyperattenuation. You have an island sign and something called as a satellite sign. Island sign, we have isolated bleeding nodules apart from the main ICH you have. In case of satellite, you have only a single nodule, which is at the distance about 1 to 20 millimeter from that of the hematoma. So this indicates there's a signs of active hematoma expansion. After seeing the location, volume, expansion, another important thing we have to see is the perihematomal edema. Edema progressively spreads within 24 hours. It will increase rapidly at the 3 days post ictus. It will peak at 4 to 5 days. It remains up to 14 days. Perihematomal edema is a prognostic factor for the death and the dependency of the patients who come with ICH. So we can see here we have the hematoma and the yellow lines, which is about minimal distance. As the day progresses from the day 2, you see it is progressing. The distance from the margin of the hematoma, that of the edema progresses. As you see in the 7th day, there is a significant perihematomal edema that has been present. So it is important to assess for the perihematomal edema also. So what is the pathophysiology behind this? Is within few hours of your hematoma, there's a clot retraction that happens that will result in the interstitial osmotic pressure to increase. It causes decrease in the metabolism. It causes cytotoxic edema, and that will result in perihematomal edema. There is thrombin, fibrogen, platelets that are released from the lysis that will stimulate our coagulation cascade, increases the inflammatory response, free radical generation, along with the aquaporin 4 and metalloproteinases, and it results in the breakdown of your blood brain barrier and causes vasogenic edema. Both cytotoxic edema and vasogenic edema contributes to formation of perihematomal edema. Why is this important to understand? This is because our target therapies are directed towards preventing these mechanisms. So we saw the location, we saw the volume, we saw the signs that will identify the hematoma evacuation. What are the other things that we can pick up? It is the intraventricular hemorrhage. It is very important to see the intraventricular hemorrhage to identify it in the patients with ICH. The expansion of hematoma, which are located near the ventricular system, it will cause the break in the ventricular wall. It leads to the intraventricular hemorrhage. About 45% of the cases will have intraventricular hemorrhage. The high incidence of intraventricular hemorrhage is seen in thalamic and the caudate bleedings. There is blood within the ventricular system. It will cause hydrocephalus because you have a reduced CSF absorption. IVH is there. It is strongly associated with a pre-hospital loss of consciousness. Suppose a patient presented with a loss of consciousness and you know it is caused probably ICH related, so definitely look in for as IVH. So based on all this, why is CT so important to us? The findings in the CT will help us gives us a significant predictors which can identify the outcome of this patient in the ICU period. So what are the predictors of ICH outcome that we can see on CT? First one is the hematoma shape and density. It is a predictor of hematoma expansion. Irregular shaped hematoma are more likely to expand. A mixed density hematoma is more likely to expand. Hematoma volume. It is a predictor of hematoma expansion, volume more than 630 ml. You have the outcome and 30-day mortality predictor. If you see the sensitivity of the performance matrix of hematoma volume, the sensitivity is about 96% and the specificity is 98%. So you know how your patient would progress because your volume is going to be large and how intense it should be a therapy. The various other predictors we have is the spot sign, swirl sign, black hole sign as we discussed, blend sign, island sign, and a satellite sign. All of these are predictors of hematoma expansion. The specificity is somewhere between 50% and the sensitivity around 80% for these things. But the most important predictor of this ICH outcome here is your hematoma volume. Based upon the patient's clinical condition, based upon the CT imaging, we can form a ICH score similar to WFNS scoring as in SAH. So we have an outcome risk stratification scale, that is the ICH score. It was developed for the logistic regression model for the patients. So whatever parameters they have included in the ICH, they are the strong predictors of outcome. Following all these parameters, they formed a score giving a score of 0 to 5, and they formed something called as ICH score. It is an important prognostic score which involves the GCS. GCS has three categories again. You have the age of the patient, what is the volume of the ICH, whether the ICH is having associated with the IVH, as we know it is significant, whether the ICH is situated in the supratentorial compartment or in the infratentorial compartment. So based on this, you give a points of 0 to 1 and a total score of 0 to 5. So based upon the scoring system, we can give a mortality of these patients. So as we see in this slide, the overall 30-day mortality in patients with ICH is about 40%. When your score is 0, there's no mortality. When your score is 1, the mortality is about 20%. But your score becomes progressively high, your mortality also keeps increasing. The 30-day mortality is about 90%. Looking at the modified Rankin scale at 12 months, when the modified Rankin scale is less than 3%, when the score is 0, the percentage of the patients is high. As the score increases, the percentage of the patients having a good outcome progressively reduces. So this helps in prognosticating also. So this patient has come to the ED. ABC has been done. You have airway breathing circulation is stabilized. We have done this. We have done imaging. So we have done the ICH scoring of this patient, and this patient has to be further wheeled in to the NCCU or a dedicated stroke unit, because there's a grade 1 recommendations that these patients has to be managed, has have a good outcome if they are managed in a dedicated stroke unit. So what should be our approach to a patient once he comes to the ICU? We should have a quick history taking to be done, presenting complaints, last known well, symptom onset and progression, functional baseline of this patient. What are the past medical history, whether he has undergone a recent trauma or the operations, what are the comorbids he is having, diabetes, hypertension, renal diseases, because they are all more prone for ICH. Is he having any past history of intracerebral hemorrhage or having a vascular lesion, that is blood again, having a liver or a renal disease, what are the hematological problems he has, or a tumor or a malignancy where there is hemorrhagic complications are more. What are the drug histories, whether the patient is on any anticoagulants, antiplatelets, antihypertensives, because they require a prompt reversal in order to prevent our hematoma expansion, which is detrimental in our patients with ICH. Looking at the personal history, whether smoking, alcohol intake, whether this will predispose more to our patient with ICH, and review of these systems. Coming to the blood test that we have to consider in this patient is a complete blood count. When you do a complete blood count, when we see there is a white blood cell count is increased, it demonstrates there's some underlying infection which we have to actively treat. The red blood cell count demonstrates whether there's a concurrent systemic bleeding is happening if the patient is on any anticoagulants, antiplatelets. And platelet count is very important because we have to assess whether this patient needs for transfusion or if he is undergoing any surgical procedures. And electrolytes, guide replacement of the electrolytes as a part of supportive care. And you have to guide our hyperosmolar therapy because these patients definitely have a raised ICP. Renal function test, what is the risk assessment for this ICP patient? Patient with a history of CKD are definitely increased risk of ICH. And glucose, it will guide supportive care and need for feeding. It is an important predictor of outcome also. And coagulation studies are PT, APTT, INR, because we have to reverse them, and the replacement of the coagulation factors, all that is important. And urine analysis, toxicology screening, it will rule out pregnancy and exclude proteinuria associated with the pregnancy. The toxicology also becomes important. So what is the care pathway? Once we have established the diagnosis of ICH, and the four important things that we have to do is the blood pressure control. We'll discuss further in detail about this. Next important, reversal of coagulopathy. Why do we need to do this two things immediately is to prevent the hematoma expansion. The risk of hematoma expansion is very high in the first 6 hours of presentation of the patient with the ICH. However, about 12% of the patients can still have hematoma expansion up to 24 hours. But it is prime important to prevent the hematoma expansion. Blood pressure control, reversal of coagulopathy, because these patients are on coagulopathic, anticoagulant drugs, and assess for elevated intracranial pressure. Because of the acute mass effect, these patients can present with the raised ICP-like features. To assess whether they need a EVD insertion, a prompt neurosurgical reference is very urgent. And looking for the other, assess the systemic complications that are secondary to ICH. They are the non-NSTEMI or the ST segment elevated MI. Aspiration pneumonia can be there because of obtundation, neurogenic pulmonary edema, there can be ulcers, acute renal insufficiency, diabetes insipidus, cerebral salt wasting syndrome. and SIADH. So look for the systemic manifestations of the ICH. Coming to the first important thing is the blood pressure management. Blood pressure control is recommended, but how we do is not a clear-cut pathway. Increase in blood pressure, we know it is going to expand our hematoma. It causes more neurological deficits, poor outcome. In the same way, if we lower the blood pressure, it is going to reduce the cerebral blood flow, cause cerebral ischemia, and for more detrimental. So, what are our blood pressure targets? How fast should we reduce the blood pressure? The randomized control trials in this has been very equivocal. Let us look into the important trials for the blood pressure management in the ICH. The first trial is attached to Interactive trial, ICH adapt trial, and the rapid blood pressure in acute cerebral hemorrhage feasibility and safety. Coming to the attached to trial, it was a multi-center randomized controlled trial. It was done in the duration between 2011 and 2015. It was done mainly in US, Japan, and China. And it is the clinical question they wanted to answer was whether lowering the blood pressure in the patients who are presenting with hypertension in ICH patient would do any benefit. So they had two groups of patients. One is the intense control of blood pressure between 110 to 139, and the other one was a standard group where it was between 140 and 179 millimeters of mercury. So they used antihypertensive agents, initially IV nicardipine, and the second line of agent was labetalol. So they took a target of 110 to 139. So in between the groups, they compared. The primary outcome was 90-day mortality or the severe disability score, that is on your modified Rankin score of 4 to 6. So, what was the result that they saw? There was no difference in the outcome of the death or disability between the intensive group or compared to that of the standard treatment. Even when the blood pressure was intensively controlled from 110 to 139 and left alone with 140 to 180, there was no difference in the outcome. But, however, there was a higher rate of renal adverse events in the patients under intense treatment within 7 days. They had higher rates of renal dysfunction in these patients. But the subgroup analysis, if the patient was having spot sign, they saw that the hematoma expansion did not show any benefit. This trial was stopped because of the futility of the trial. It was stopped prematurely. So, if you see the primary outcome of this same trial, what they saw in the intense treatment when the blood pressure was less than 140, it was 38.7, and the standard treatment group, the primary outcome, the death mortality was almost same, 37.7. So the conclusion of the study is the treatment of the participants with intracerebral hemorrhage to achieve a systolic pressure of 110 to 139 did not result in the lower rate of death or disability than the standard targets of 140 to 179 millimeters of mercury. Then came the Interact 2 trial. They also divided into two groups, which was a treatment group. They maintained the blood pressure less than 140. But whereas in Attach 2 trial, the blood treatment intensive group, the pressure was between 110 to 139 millimeters of mercury. Here they divided between 140 to 180 millimeters of mercury. So the comparison was a target systolic blood pressure of less than 140 compared to the systolic blood pressure of less than 180 millimeters of mercury. They maintained the blood pressure targets up to 7 days, whereas in Attached trial, the blood pressure targets was maintained only up to 24 hours. The primary outcome, what they wanted to see, was a 90-day death and 90-day death and moderate or severe disability. The MRS was between 3 and 6. The result is no difference between the two groups in terms of the main outcome. There was no mortality benefit. In a pre-specified ordinal shift analysis, what they said, the functional outcome was better if you had maintained the blood pressures in the intensive group compared to the non-intensive group. That is, when the blood pressures were less than 140, the functional outcome was good, but the mortality benefit was not there. The serious adverse events were similar between the two groups. Coming to the next trial, we have the ICH ADAPT trial and a rapid blood pressure reducing in acute intracerebral hemorrhage trials. In this trial, like when they lowered the blood pressure to less than 110 millimeters of mercury and the standard treatment. The clinical, what they saw was a neurological deterioration between the intense control group and the standard therapy group. When they saw the second, there was no significant difference in the neurological deterioration. Secondary outcomes included the MRS at 90 days and and 24 hours hematoma enlargement, there was no significant difference. So we do not have a clear cut idea about the trials, did not give a clear cut measurements. However, from the various trials, we have a 2022 guidelines for the management of the patient with a spontaneous cerebral hemorrhage, which suggest in patients with spontaneous ICH who require BP lowering, careful titration has to be done. You should ensure it's a smooth transition, sustained control, avoid the peaks and large variability in the systolic blood pressure. It is more beneficial in improving the functional outcome. It was a level 2A recommendation. So, what is harmful? If the patient is having spontaneous high CH, presenting with a mild to moderate severity, has a BP of more than 150, you acutely lower it to less than 130, that is being very harmful to this patient. So, what is the sweet spot that we have to maintain the blood pressure in these patients? In patients with spontaneous ICH with mild to moderate severity, presenting the systolic BP of 150 to 220 millimeters of mercury, acute lowering of the systolic BP targets to 140 millimeters of mercury. The goal is to maintain in range between 130 to 150 millimeters of mercury. This is a safe recommendation and may be reasonable for improving the functional outcome. So when you are maintaining the blood pressure, three important principles is, because we do not know which is the ideal blood pressure. So most studies indicate that the high blood pressure is harmful. So what is the target blood pressure? According to the guidelines, you maintain at 140 millimeters of mercury in the range of 130 to 150 millimeters of mercury. Three things to remember: fast, intense, and a stable blood pressure control. Fast is if the blood pressures are high, as soon as possible, take measures to reduce your blood pressure. Intense is start a rapidly active drug, titratable drug, and control the blood pressure, and it should be stable. The wide variability in BP swings is not advocatable. It's bad. Use a fast acting controllable IV medications. So this is the basic management of blood pressure. Another important factor, the patient usually is on anticoagulants or anticoagulation associated ICH. Anticoagulants are the strong predictors for your hematoma expansion. The use of anticoagulants have significantly increased in the last decade. Threefold increase in the incidence of anticoagulated related intracranial hemorrhage. Hence, it is a very important topic. There is an increased risk of hematoma expansion. This will result in a very poor outcome. So, this is an initial scan of a patient who was on warfarin, initially presented with a very small hematoma. A warfarin reversal was done. In spite of this, at 10 hours, we could see that there is a rapid hematoma expansion and a devastating head outcome in this patient. So, what are the main goals when we have an anticoagulant associated ICH? You have to withhold the culprit drug. You reverse the drug effect by administration of antidote when it is available. You monitor the effectiveness of your reversal by doing appropriate laboratory test. One thing we have to bear in mind: laboratory correction of coagulopathy will not ensure that the in vivo correction of coagulopathy has been happened. So definitely it is of utmost importance. So how do we reverse this anticoagulation? Patient usually are on anticoagulants, antiplatelets, and thrombolytics. So let us deal with each agent. Coming to the vitamin K antagonist, warfarin is the most important prototype we come across. There is an increase in the use of warfarin with atrial fibrillation. It is increased fourfold over the last decades. And VK is associated with a 12 to 14% of all the intraparenchymal hemorrhages. Hence, a prompt reversal of warfarin has to be done with vitamin K, prothrombin complex concentrate, FFP, and recombinant factor 7. Let us see which is the best agent to reverse this. All these agents are effective in reversal of the VKS as alone? No. They require they cannot act as a monotherapy. They require multiple. The efficacy, timeliness, and the safety of it varies. Coming to the first one is the vitamin K. It normalizes the INR by providing the necessary substrate to synthesize these coagulation factors. But the reduction of INR less than 1.4 will take up to 24 hours. We do not have that much time because hematoma expansion is high in the first 6 hours. So monotherapy alone is not useful in this case. There is a delayed onset of action of vitamin K, but it provides a sustained and a durable reversal of anticoagulant activity in conjunction with another agent. So, intravenous administration of vitamin K is more effective at INR than the subcutaneous route. So, the route of administration of vitamin K is also important. What is the risk with vitamin K? The risk is very low. We can easily give vitamin K, but there is a risk of anaphylactic reaction, but it is a very rare. The incidence is only 3 per 10,000 doses of vitamin K is being used. And the next easily available is your FFP. Is FFP contains all the coagulation factors and proteins. It will reverse the anticoagulant effects of VK by replacing the clotting factors, but the degree of normalization depends on the initial INR of the patient. Like a very high INR then requires more dose of FFP. The typical dose range will from 5 to 20 ml, but a dose of 30 ml will produce a more complete correction of the coagulation factor levels. So the time of correction, like for FFP, will limit the utility of the FFP. So there was a study by Marcus et al. Like how fast the INR gets corrected with FFP. In this study, they found that when they had given FFP about 800 ml in 41 patients, they could find that the INR did not correct less than 2 within 15 minutes of post infusion. Definitely, time efficacy is a problem. To see the advantages and disadvantages, advantages, FFP is very cost effective. It's widely available. But if the patient is allergic to prothrombin complex concentrate, your option is to give FFP. If the prothrombin complex concentrate fails to correct your INR, you cannot repeat a prothrombin complex concentrate, but you can correct it with FFP. The disadvantage is delayed time of action. It is not fast acting like prothrombin complex concentrate. The risk of pulmonary edema when you are giving large volumes and rapid transfusion, the risk of tacho and trally, failure to correct INR will lead to heart failure in these patients, will result in hepatoma expansion. Sorry. What is the advantages of prothrombin complex concentrate? It contains variable amounts of all the factors 2, 7, 9, and 10, protein C and S and Z and heparin. In India, most commonly available octaplex and beriplex, 4-factor PCC. The advantages of it is a fast preparation. It doesn't require any thawing. You can just draw like any other medicine and give immediately, not like an FFP you need to thaw. The reconstitution time is very early. It results in rapid INR reversal, which is very important for us. It has a lower risk of infection because you're not giving a blood product here. It's a weight-based dosing of PCC is more effective, and you give a very small volume of infusion, 15 units per kg body weight. Another, apart from PCC, vitamin K, and FFP, do we have another option? Is the recombinant factor 7. It also results in rapid INR reversal like of PCC. There is a very limited data to support the hemostatic effect or the functional outcome or mortality benefit after giving recombinant factor 7. But it has a highest thrombosis rate, which is about 12.8% to 24%, unlike a PCC or a FFP. It has a procoagulant state and a thrombin burst is associated with the higher doses. It is very expensive and not preferred. This study is a multicentric study where they compared the efficacy of 4-factor PCC and an FFP with the patients who are on vitamin K antagonist. So this was a multicentric study. They saw in about 36 states across. So what was the conclusion? They compared with the PCC group and the FFP. The rapid INR correction was definitely high in the PCC group, about 62.2%, unlike the FFP group, which is only about 10%. The hemostatic efficacy was better, about 72.4%. However, the thromboembolic phenomenon was a bit more compared to that of the FFP. The fluid overload was about 4.9%, whereas in FFP group, it is about 12.8%. Definitely, PCC had an advantage over the FFP. So coming to the part after the vitamin K antagonist, next we have is a direct factor 10A inhibitors. The agents are rivaroxaban, apixaban, endoxiban. Easy to remember as direct factor is XA. Rivaroxaban, apixaban, endoxiban. So the current indication for using is a non-valvular AF. So how do we reverse this factors? Is an activated charcoal. Hemodialysis is not effective because they are protein bound. Administer 4-factor PCC, activated PCC, or in case of intracranial hemorrhage, occur within 3 to 5 terminal half-lives. Next agent is a direct thrombin inhibitors, dabigatran, which most commonly see use of dabigatran. it should be stopped, discontinued as soon as the ICH is suspected. If the DTI is administered in the last 3 to 5 half-lives, it has passed 3 to 5 half-lives, then before administration, no role for anticoagulation because it has negligible effect. The specific antidote for the dabigatran is idrecuzumab. Idrecuzumab is a specific neutralizing monoclonal antibody fragment that is available. It adheres to the thrombin binding site of dabigatran. It is approved by FDA in 2015. It has higher affinity for dabigatran than the thrombin. It will make the dabigatran inactive. Once it forms a complex with the idrecuzumab and the dabigatran, it is cleared by the kidneys. It normalizes your APTT values. Another agent we use most is a patient who comes thrombolized for the ischemic stroke. We have fibrin selective agents and fibrin non-selective agents. They are the symptomatic intraparenchymal hemorrhage with mass effect occurs in 2 to 7% of the patients whom we thrombolize. The recommendation is discontinue the thrombolytic agents as soon as you suspect. When there is a 4-point decrease in your NIH scale and patient is attended, you have to immediately suspect it is a hemorrhagic or the ICH. Discontinue thrombolytic agent, arrange for the cryoprecipitate, and the prompt reversal is required. Most common practice we come across is our heparin, unfractionated heparin, and low molecular weight heparin. The specific antidote for heparin is the protamine sulfate. So protamine sulfate is given at the dose of, to easy to remember, as 1 milligram of protamine for every 100 units of heparin that we have used in the preceding 3 hours. So this has to be done. If the patient has received a prophylactic heparin is in the subcutaneous dose, there is no need to give protamine unless our APTT is very much prolonged. It is unusual, but it doesn't happen. There is no need to reverse the subcutaneous dose of heparin. Coming to the low molecular weight heparin, the protamine sulfate is also preferred for the low molecular weight heparin. About partially reverses the action of the low molecular weight heparin, not like heparin. The low molecular weight heparin, about 60% of the activity is reversed when we are using protamine sulfate here. If the patient is on the prophylactic dose of low molecular weight heparin and it is elapsed more than 12 hours, there is no need to reverse this anticoagulation. Only when they are on the therapeutic dose, we have to administer protamine sulfate. Next, patient usually is on aspirin or a clopidogrel or the pasugrel or the antiplatelet agents. Should we reverse this? The level 1 recommendation says there is no need for prophylactic administration of platelets if the patient presents with ICH having taken the antiplatelets. Only if the patient is going for any surgical procedure, neurosurgical procedures, even an EVD insertion, platelet transfusion is advocated. Otherwise, they should not receive any administration of the platelets. However, recently there is a role for desmopressin, which we will discuss in the subsequent slides. So, to put everything together, regarding the anticoagulation, if the patient with ICH comes on anticoagulation, discontinue the anticoagulation therapy immediately and rapid reversal should be performed as soon as possible. This is a class 1 recommendation always. So if the patient is on vitamin K antagonist, you know if the INR is less than 2, you give about 4 factor PCC immediately, the 20 international units per kg. But if the INR is more than 2 and you want rapid achievable of reversal less than 1.4, you give about 50 international units per kg of 4 factor PCC along with injection vitamin K, which is a class 1 recommendation. Coming to dabigatran, if the patient is on dabigatran, you have a specific antidote. You have to take an history when it was last taken. Suppose if the patient is last taken less than 2 hours, you have an option of activated charcoal. Again, there's a risk of aspiration. The installation of Ryle's tube and then charcoal administration would be better. And the specific antidote is the idrecuzumab. If you do not have idrecuzumab, it is a 4-factor PCC to be advocated. And coming to the factor 10A inhibitors or the XA inhibitors, it is rivaroxaban. You have a specific antidote of adenexate alpha, but it's not available in India. It is a 4-factor PCC or the activated PCC correction is required. Coming to the heparin to be unfractionated heparin class 2A recommendation with the protamine, and low molecular weight heparin is with the protamine. So this is the summary of our anticoagulation. So what is the role of desmopressin? If the patient is on antiplatelets like aspirin or clopidogrel, a single dose of desmopressin improves the outcome because it improves the platelet function and reduces the incidence of hematoma expansion. There is a recent pilot study which evaluated this role. It improved the platelet function and reduced the which is reduced by the platelet activity. So the desmopressin, a single dose of zero point 0.4 micrograms per kg IV given over 30 minutes, it increases the platelet activity. But however, the effectiveness of DDAP was very short-lived. Based on these limited data, a single dose considered for the patient who is with aspirin or ADP receptor inhibitor associated ICH can be considered. So this is the summary of the recommendations that we discussed. So I'll be moving on with the slides. So, antiplatelet related hemorrhage, we know that for patients with spontaneous ICH being treated with aspirin who require emergency neurosurgical procedure, only then platelet transfusion might be considered. But otherwise, there is no role for platelet transfusion. For patient with spontaneous ICH being treated with aspirin and not scheduled for any emergency surgery, platelet transfusions are potentially harmful and should not be administered. Coming from the blood pressure management and other reversal of anticoagulation, the next management of the ICP, and then comes the surgical approaches. The various surgical approaches in these patients are EVD insertion, craniotomy and hematoma evacuation, decompressive craniectomy, neuroendoscopic procedures, and minimally invasive surgeries. So there are several trials which compared the effectiveness of doing a surgery in a patient with ICH or continuing with a conservative management. This study was in 1961, which compared between the craniotomy and the conservative management. The authors were unable to demonstrate any benefit of surgery in patients with supratentorial tumors. So next, the other type of surgery was an endoscopic guided evacuation. This was in 1989. They saw lower mortality and higher rates of favorable outcome in the surgical group. But these results was seen only in the patient who had a lobar hematoma, who had a small hematoma. But if the hematoma with the ICH was in the basal ganglia area and they had operated, the outcomes was extremely poor. And we had other trial which is a prospective single center trial which compared the craniotomy. They said that the surgery did not offer any advantage over the conservative management. In surgery decreased the mortality, but patients survived with poor quality of life, so the outcome was definitely not good with surgeries. Then came the stitch 2 trials and the misty 2 trials. In stitch 2 trial, they compared with craniotomy, craniectomy, and minimally invasive surgery in patient with supratentorial ICH. So they were randomized within 96 hours of admission. About 59% of the surgery group patient had an unfavorable outcome versus 62% of the patient who had a conservative management. There was no overall benefit in the functional outcome or the mortality by offering the patient the surgery. Then came the MISTY trial, which is the randomized control trial. It is image guided catheter based. It is stereotactically you place the catheter and instill an altive place so that it will reduce the hematoma volume. So the outcome of this was the primary outcome did not differ between the groups. That was the outcome was 30-day mortality was not different between the group. Asymptomatic hemorrhages were more common in the surgical group. Asymptomatic hemorrhages, that is the rebleeding and the chances of ventriculitis, were more in the patient who had this surgery done. Then came the CLEAR 3 trial in which they put the catheter and instilled the thrombolytic agent to reduce the volume of the hematoma. But the injection of the intrathecal alteplase did not improve any functional outcome in these patients with the IVH. The modified Rankin scale was not better when they did the treatment. Treatment was associated with a lower case and the cost was higher proportion and the patient was in the vegetative state. So it was not clearly advocated. Then the MISTY 3 trial came, which is the minimally invasive catheter evacuation of the hematoma followed by thrombolysis, that they instilled the thrombolytic agent. So the MISTY 3 trial also did not have a long-term outcome. Out of the 110 patients they saw, the 41% in the conservative group achieved a favorable outcome. So meta-analysis included only the multi-site trials and the MISTY 3, so it did not offer much benefit. But compared to supratentorial fossa, what we see now, posterior fossa intracranial hemorrhage is a different ball game altogether. The bleeding that takes place in the cerebellum and the brainstem is very crucial. It occurs in 5 to 13% of all the ICH cases. As we know, infratentorial compartment is very narrow and tight. They dramatically have a neurological deterioration because they have developed an obstructive hydrocephalus because of the obstruction to the CSF flow, and the local mass effect that will cause on the brainstem compression, which will obtain the patient very early. So, what are the surgical options we have in posterior fossa? They are the suboccipital decompressive craniectomy, EVD insertion for hydrocephalus management, and any conservative management are based on class 3 studies. But if you have a bleed in the posterior fossa ICH, which is more than 3 centimeters, cerebellar hemorrhage, which is compressing the brainstem compression, you have seen the quadrigeminal system being effaced, it is causing acute hydrocephalus, it requires a surgical management. Apart from the blood pressure control, hematoma expansion with reversal of anticoagulation, the surgical management, we have several supportive care that we have to give in ICU. So let us discuss on this. It is first thing is the hyperglycemia. Hyperglycemia is common in patients who are presenting with the ICH. Again, if the volume of the ICH is large, they have increased incidence of hyperglycemia. It is associated with a poor outcome because it results in hematoma expansion, increased edema, and death. So the optimal glucose levels and the best hyperglycemia management is not clear. But however, the hypoglycemia and hyperglycemia should be definitely avoided in these patients. Fever is another important thing we have to combat in ICU with this patient. It is independently associated with the poor outcome. About 50% of all the patient will present with high fever in patients with ICH. The presence of IVH is the main risk factor for fever, not explained by the infection or the drugs. The suggested goal is to keep a core temperature below 37.5 to 38 degrees centigrade. There was a ICOOL 1 pilot study where they induced normothermia using cold saline infusion with the nasopharyngeal cooling. No benefits as such. Seizure is another thing. Seizure frequency has been reported between 8.1% and 10.6% in patients with the ICH. Early seizures are seen about 4%, and another 6% you have a late onset seizures. But however, status epilepticus is only about 1 to 2% in this patient, especially with a lobar or a cortical involvement of an ICH. There is no role for using a prophylactic use of anticonvulsant in this patient. It causes worse outcome, especially if you're using phenytoin as a prophylactic use. Suppose if the patient is having ICH, has a decreased level of consciousness, which is out of proportion to your radiological findings, then it is deemed to look for a continuous EEG monitoring to rule out a non-convulsive status or in these patients. Otherwise, there is no role for prophylactic administration. Another thing we have to see every day is the venous thromboprophylaxis in this patient. There is a high risk of venous thromboembolism, about fourfold higher than in patients with ischemic stroke. The initial prophylaxis, immediately you have to start with the pneumatic compression devices, followed by, once the patient is stabilized, to start with unfractionated heparin or the low molecular weight heparin. So when do we start this? It should be initiated once we document the cessation of bleeding by imaging. It usually 24 to 48 hours after the initial hemorrhage. It's the same to 2022 guidelines, which says that as soon as the patient comes in a non-ambulatory patient, start with the pneumatic compression devices. In non-ambulatory patient with spontaneous ICH, low dose or unfractionated heparin or low molecular can be useful to reduce the risk of PE. It has to be started within 24 to 48 hours. So, in a non ambulatory patient with spontaneous ICH, if you are using a graduated compression stockings, it has no benefit in prevention of VTE. Dysphagia, about 50% of the patient with stroke will has a dysphagia. The incidence varies anywhere from 37 to 78%. It is associated with the increased risk of aspiration pneumonia, dehydration, malnutrition. So the ASA AHA guidelines recommend dysphagia screening should be done in all the patients before we start them feeding in patients with stroke. If you think the dysphagia is going to be very prolonged, enteral feeding via temporary gastrostomy may be warranted in these patients. So after managing the blood pressure and anticoagulation or surgical management, what is the role of monitoring? The uncertainties remains regarding the ICP monitoring in these patients. There is no data that has been clear. There was a Synapse ICU study that recently came out in 2018 around. where they compared the ICP monitoring techniques in patients with acute brain injury that comprises of TBI, ICH, and SAH. So they had all the three groups, but core ICH was not there. So the same investigators of the Synapse ICU study pulled up the data from the ICH cohort, and they gave a few insights to it. They compared that what was the clinical practice of ICP monitoring when these patients, whether they did an intraventricular devices or a parenchymal devices. So, and how many times was there intracranial hypertension episodes that were recorded? How was the therapeutic management? Like, what was the ESF diversion? What was the hyperosmolar therapy they did? And in hospital mortality, was there any change? And whether 6 months mortality and outcome was a change? The conclusion of the study is the use of ICP monitoring and its treatment will reduce the 6 month mortality, but doesn't seem to it reduces the in hospital mortality but does not improve the 6 months functional outcome. So in this study we can see that is red color is with the ICP monitoring, and the green is with the no ICP monitoring. Looking at the hospital mortality, as the ICH score goes up, the mortality is less when they're done ICP monitoring, but definitely the mortality is high when there was no ICP monitoring. The number of CT required was high in the patient who had their ICP monitoring done. The number of hyperosmolar therapy or the interventions for the raised ICP was better managed. The intensity of the treatment was high if the patient had the ICP monitoring. It reduces your mortality, but overall the 6 months outcome did not differ. However, it requires further management. So, what is the guideline says regarding the ICP? In the patient with spontaneous ICH or hydrocephalus, if it is contributing to the consciousness, it requires a prompt EVD insertion. In patients with moderate to severe ICH, reduced level of consciousness, ICP monitoring and treatment might be considered. It will reduce your mortality and improve the outcome. Similar to our TBI guidelines, a strict no to the corticosteroids when the patient is on is a case of ICH. So all of this we are treating in ICU. We need to have the predictors of functional outcome. We need to prognosticate as how a patient is going to move on. So what are the important predictors of the functional outcome in the ICH? It is the hematoma volume, ICH volume of more than 60 ml, and the CT image, and the GCS of less than 8. The product mortality is about 90%. Look at for hematoma location. Hematoma expansion in first few hours, significant outcome is doubtful. And CT angio spot sign, it will tell about the functional outcome and the mortality benefit. And admission anemia is always associated with the hemorrhagic expansion and the poor outcome. So let us look into the key recommendations, which are the class 1 evidences from 2022 guidelines. Is that if the patient when do you do CT angio in all the patients? Suppose if it's an hypertensive bleed where there's no, when the patient's age is more than 70 years, there is no need to do CT angio. But however, it is reasonable to do to look for the signs of active hematoma expansion. In patients who have lobar spontaneous ICH, the age is less than 70 years, you have a posterior fossa spontaneous ICH, age is less than 45 years, it's a class 1 recommendation to consider to do CT angio to look for the etiology of the ICH, not to miss the vascular lesions. If the patient is having a spontaneous IVH and is not having a parenchymal IVH, it is necessary to do a DSA to rule out any macrovascular causes which is not picked up by CT angio. So in MRI and MR angiography should be considered in patient with a spontaneous ICH and having a negative CT angio or a venogram to establish a non-macrovascular cause of ICH. In these cases, consider doing an MR angio. So class 1 recommendation again for your vitamin K antagonist is a 4-factor prothrombin complex, which we have discussed. And do not give any platelet transfusion for the patient with a spontaneous ICH and with aspirin unless the patient is going for surgery. And in patient with a spontaneous ICH, if you provide the care in a patient with stroke unit or a dedicated neuro center, the multidisciplinary team involvement has a better outcome. It is a class 1 recommendation. And to start a low molecular weight heparin in these patients to reduce the risk of pulmonary embolism is a class 2A recommendation. In the patients with a spontaneous ICH, baseline severity score should be the only predictor used for the prognosis or considered limiting in the life-sustaining treatment. So this is a brief insight, like we have already discussed in these lines. The patient comes, medical stabilization. The patient comes with this history, clinical presentation, you go by the order of A, B, C. If airway, if the GCS is less than 8, you go ahead and secure the airway. If you think that has been threatened airway, to intubate the patient, maintain adequate oxygenation, and your PaCO2 between 35 and 40 millimeters of mercury, and hemodynamic resuscitation has to be done. Established adequate monitoring in these patients, and take key history findings, what was the comorbidities, baseline functions, and anticoagulations, and measures to prevent the hematoma expansion, rapid blood pressure control, and you have to do a correction of your coagulopathy. And following this, we saw that imaging things. In imaging, you will look into the location of the, where is the hematoma, identify the hematoma, identify the location of the ICH, look into the volume of the ICH, look at the edema around it, and look for the signs whether it is an expanding hematoma. So these are the things you have to consider. If the patient is having a deep basal ganglia, you think it is because of hypertension, there is no further imaging that is required. But if it's a subcortical non-lobar, then it is, you have to do a CT angio, consider DSA has to be done. So prompt, consider surgical interventions if the patient condition in the raised ICP is because of your IVH or hydrocephalus. EVD insertion is very important. Location of ICH in infratentorial ICH, an early surgery is mandatory, but in a supratentorial ICH, the surgical early surgery is not preferred. Only if there is further neurological deterioration and worsening of the patient, the surgery has to be offered. And other preventive measures is management of a raised ICP, management of the raised ICP in terms of hyperosmolar therapy and tire therapy. Seizures, there is no role for prophylactic treatment, and general ICU management. Early enteral nutrition. So we have to establish feeds within first 24 hours. So by day 2 or 3, we have completely established the complete caloric requirement. Avoid hyperglycemia as we discussed, and avoid hyponatremia or hypernatremia, because it worsens our cerebral edema, which we don't want. And monitor for normothermia, and prevention of venous thromboembolism is utmost important. Brief discussion about the antihypertensive agents that we use: labetalol, enalapril, nicardipine, and esmolol. Nicardipine more common in the West, and we do not have nicardipine. Most commonly we use with the labetalol infusion. Following the labetalol infusion doesn't get controlled, can hike up to IV nimodipine, and put in a Riles tube and start with the oral agents. Once the oral agent starts taking off, the labetalol can be titrated well better. Next, the small dose of NTG can be used if you are not able to control with the labetalol with IV nimodipine. Usually it gets controlled by then. Otherwise, NTG for a short period of time can be considered in these patients. So this is a tick boxes that we have to complete in the first hour when the patient comes to us. With the complete blood count, a platelet count, head imaging has to be done, GCS, ICH scores, and the interventions. What we have to do is remember to reduce your INR to less than 1.4, achieve a blood pressure goal of 140 to 180 millimeters of mercury, a surgical hematoma evacuation if it is indicated with significant mass effects, midline shift, patients having anisogoric pupils, and airway and effective ventilation management is very important. In the ICU, what we need more important is an ICP monitoring. The benefits are definitely there, or following in ventriculostomy. Continue management of blood pressure. It has to be continued in the first 24 hours. Place an arterial blood pressure because it gives you a beat to beat variation and more accurate in titrating this antihypertensives, because they're on IV antihypertensives. Place a central venous catheter for a good drug delivery, better drug delivery. And urine toxicology screening if it is not already done, because we want the etiology of our ICH. Foley's catheter, very much important. These patients are on hyperosmolar therapy, guided for the management. And feeding tube to establish feeding. DVT prophylaxis has to be done in these patients. Like we have many ICU care bundles. Is there in an ABC bundle for intracerebral hemorrhage? The A stands for rapid anticoagulation reversal, B stands for intensive blood pressure controlling, and C stands for the care pathway, where you give a prompt neurosurgical referral. That is A, B, and C. Whether implementing this care bundle will improve the reduce the case fatality rate. So this was an important study. It was done in UK. There is an intracerebral hemorrhage care bundle, which was the ABC bundle what we described, is associated with a lower case fatality rate. So they saw before implementation, during implementation, and after the implementation of this ABC bundle. So door to needle time, what is the DNT, was about 132 minutes initially before implementation. After implementation, it reduced to 105 minutes. And NTT is the needle time to target. That is the time taken for your blood pressure control, was about 383 minutes before we implemented this bundle. But during implementation, it reduced to about 43 minutes. And after implementation, it is about 50 minutes. So definitely it did a change. So what they saw was the survivability. Did it increases the survival probability by using this bundle? The solid line, what we see is before the implantation. The dash lines are what we see when it was during the implementation, and the dotted lines are seen after the implementation. Definitely after this implementation of this ABC bundle, we can see a better survival probability. The implementation of the ABC care bundle was significantly associated with a lower mortality in patients with ICH. So the conclusion of this is the ICH is a neurosurgical, is a neurological emergency. It has high morbidity and mortality. The four important things we have to see is a control of blood pressure, reversal of anticoagulation, surgical management when deemed appropriate, and a prompt etiological diagnosis. With this, I end my talk. Thank you very much.
Thank you, ma'am. Thank you for that extensive presentation on ICH. It clarified a lot of things on, the steps to be followed and the bundle of approach. Obviously, it's worked in many aspects of critical care management, starting from VAP rates. So I hope this class gave a lot of clarity and gave an approach on how to manage a patient with intracranial hemorrhage. Thank you, and we look forward to seeing you on many more forums on the Neurocritical Care Society of India. Thank you very
Thank
much.
you, Matangi. Thank you for this opportunity.